That is, we consider them as Vataja Nanatmaja Vyadis. I take this opportunity to inform Joshi sir that most of the neurological disorders which have been admitted in our hospital, during examination of the postgraduate scholars in WIMS, they do come to our hospital and they will request to send these patients suffering from rare neurological disorders a day prior to the examination. What I mean to say is, we have been treating these disorders, and Ayurveda has a definitely role to play in diagnosing and treating the neurological disorders. But still then, we all know, even allopathy doctors and Ayurveda doctors know that neurological disorders, not only it is difficult to diagnose most of the times, and also it is difficult to cure also. We will manage the disease as such. That is what I know being a surgeon. I just have a minimal knowledge about this neurological disorders. But what I know is, according to WHO, hundreds and millions of neurological disorders will be diagnosed in a year. Almost more than 6 million die because of stroke, especially in the countries of low or middle economic groups. Most of the patients die because of stroke. So what we know is at least 50 million of the worldwide population has been diagnosed with epilepsy, and almost 47.5 million have dementia, probably including most of us, and with 7.7 million new cases diagnosed each year. So such is the scenario of the neurological disorders. So what is this neurological disorder? I need not say about this, because we all know that it is something related to the voluntary or mechanical functioning of the central nervous system or peripheral nervous system is deranged. That is all. It is related to brain, spinal cord, and peripheral nervous system, right? So what we have understood is, as a doctor, is we have some 5 common symptoms. Maybe it is just a headache, or it is a dizziness, or it may be dementia, or it may be seizures, or it may be neuromuscular weakness, right? Any headache we usually neglect, but any persistent headache, which is like alternating in the presenting type, we have to think about. It will be having some serious relationship with the neurological disorders. We usually neglect, right? Because of the minimum knowledge we have about the neurological disorders. They are like 600, probably, I don't know, 600, more than 600 neurological disorders have been named till date. But most of them are presented as diplopia or headache or seizure or neuromuscular disturbance like that, commonly. So that is the very reason it is very difficult to diagnose, because as such, the causes may be very different. Maybe it is some autoimmune disorder, maybe it is a functional neurological disorders, maybe it is a degenerative changes in the brain which is presenting as neurological disorder, or some viruses, some infectious diseases, infections resulting as some neurological symptoms. There are so many causes for these neurological disorders, and we have arranged this because it is the most challenging area now. Neurological disorders are very challenging areas, and as far as my knowledge goes, this rate of neurological disorder symptoms have gone up after this COVID and this vaccination. I don't know. Maybe I am relating this disorders to COVID and vaccination. Sir should throw some light on that. As far as my knowledge goes, most of my colleagues are suffering from little bit of dementia of this vaccination, including me, dementia after this vaccination. Probably we are not accepting our age, we are relating it to the vaccination or COVID, probably in the recent days. I think this today's deliberations will throw some light. We have so many queries, doubts about this thing. I think all your queries will be answered, and all this PG scholars will be definitely benefited by this thing, because we are expert in treating Nanatmaja Vyadis, Vataja Nanatmaja Vyadis, but we should have that knowledge of this modern knowledge as well, allopathy knowledge, and the way to diagnose the neurological disorders. So probably today's deliberation will definitely throw some light, and I hope this session will be very rewarding. for all of you. I take this opportunity to appreciate and thank the NIMA women firm, the dynamic lady, Farida, Savita, Hema, and all the office bearers. I cannot take the names of everyone. I thank all of you for giving me an opportunity to address you all. Thank you one and all.
Thank you, ma'am, for highlighting important aspects related to neurological disorders. Vidya Rupam Gurupanam, Kshama Rupam Tapasvinam, Kokilanam Swaro Rupam, Strinam Rupam Patibratam. I deem it a great honor and privilege to call Dr. Savita, Secretary, NIMA Women's Forum Bellary, to propose vote of thanks. We are thankful to our Honorable Principal, Dr. Syed Akhtar Fatima, ma'am, for her enthusiastic support. I would like to thank our beloved Dr. Siddaramaiah sir. A special thanks to Dr. Siddharth Joshi sir, who made this seminar more successful. And I would like to thank Dr. Madhav Dikavi sir, and thanks to our President Dr. Fatima Begum, ma'am, and thanks to all organizing committee, teaching and non-teaching staff, and special thanks to all PG scholars for making this event successful. Thank you one and all. Thank you, ma'am. Now we have landed to the main part of the event. Let's all hold our breaths tight and welcome the guest speaker to continue with the session. Over to you, sir.
Very good afternoon to everybody. Today at this outset, before starting my talk, I would like to thank NIMA Women's Forum Badai branch, and also Tarnas Ayurvedic Medical College for having me over and giving me this opportunity to share my thoughts on movement disorders. This topic is very close to my heart. I have a special interest in movement disorders. So the topic for today's discussion will be everything that shakes is not shaking palsy. Basically, shaking palsy is nothing but Parkinson's disease. It's an old name for Parkinson's disease, which was given in 1817. So this will be a video-based approach to movement disorders. As they say, action speaks louder than words. I thought instead of putting more references, more statistics, more theoretical stuff in my slides, I thought I'd make it a video-based approach for this particular presentation. And the reason for me choosing this particular topic is, as you all know, in our day-to-day OPD practice, we come across a lot of patients with various abnormal movements. There will be hyperkinetic, there will be dancing, there will be tremors, there will be jumping, and so many movements. And as you all know, most of the time, these patients are labeled as Parkinson's disease. So they end up being labeled as Parkinson's disease, and they are put on various dopa analogs, dopa agonists, and so many other dopamine agents. And they end up coming back to us with a lot of side effects, mainly levodopa-induced dyskinesias, which are very difficult, tardive dyskinesias, tardive dystonias, which are very, very difficult to treat. Hence, I thought it will be just to give you an orientation about various other movement disorders which come across. So I'll not be talking about the treatment part, pathophysiology part. I'll not bore you people with a lot of references, statistics, genetics, and stuff like that. It will be purely video-based lecture. The theory part will be very less in this, and hope you guys like it. So, first, a bit of history. This is a shaking palsy. This is an essay written by James Parkinson in 1817, almost 2 centuries back. He's considered the father of Parkinson's disease. He wrote this essay in 1817. Mainly, he described Parkinson's as involuntary, tremulous motion with lessened muscular power in parts not in action and even when supported, with a propensity to bend the trunk forwards and to pass from walking to a running pace. The senses and intellects being uninjured. So this is the first photo of Parkinson, which is called as paralysis agitans. This was initially given in 1870. So that's how the Parkinson got its name called shaking palsy. Then this I guess everyone knows something called Sydenham's chorea. Chorea, as you all know, is a semi-purposive or quasi-purposive dance-like movements, and it got its name. It's also called a Saint Vitus dance. This is from Denmark. What happened in Denmark is, in around 2 centuries back, there was an epidemic of post-streptococcal infection causing a lot of chorea. So there they call it as Saint Vitus curse, and that's why people are dancing in that particular area, and hence it's got its name as Saint Vitus dance. That's called another name for chorea. So when you talk about movement disorders or movements in a human being, there are 3 particular main organs which you need to know, and the most important organs which help us coordinate various movements and carry out our daily activities are mainly the cortex, the basal ganglia, the main basal ganglia, and the cerebellum. These 3 are the most important organs, and any problem in these organs will definitely cause some kind of movement disorder or movement abnormality in our body. So when you're talking about movement disorders, it's a little bit of anatomy, instead of going the depth of the whole thing. So what we can do is there are 3 pathways which we need to know to make it very simplified. You have a direct pathway, you have an indirect pathway, and hyperdirect pathway. So at least 2 pathways we need to know. To accelerate, to walk, or to carry out any kind of movement, positive movement, you need the direct pathway to be there, functioning well. That is from the motor cortex to the caudate lobe. Then comes the globus pallidus or lentiform nucleus, and then the thalamus, and back to the motor cortex. In this pathway, you have inhibitory neurotransmitters like GABA and a positive neurotransmitters like glutamate will play a role. We'll not go to the depth of it. The crux of the pathway being for any motion to happen or any movement to happen coordinately, positive kind of motion. It's like accelerator of a car. You want to move forward, you want to do something, your direct pathway has to function properly. Whereas indirect pathway, any defect in a direct pathway will stop your motions, will stop functioning well, you become slow. So remember, Parkinson's is some problem in the direct pathway. When you are talking about indirect pathway, you again it's the same pathway: motor cortex, caudate, the globus pallidus, the thalamus, and then the cortex, and from there to cerebellum. So here, indirect pathway plays basically it's a play between the positive neurotransmitters and the negative neurotransmitters in the both pathways. So any problem in indirect pathway is like a brake. If you want to stop a movement, you want to stop walking, you want to stop doing something, then indirect pathway plays an important role. So whenever there's a problem in indirect pathway, anywhere among this pathway, if there's some defect, even if the neurotransmitters go down, if they get blocked, or if there's any lesion, a tumor, or anything like that, let it be water, vasculitis, demyelination, whatever affecting this part of the pathway, so everything becomes slow and everything starts to become hyper. So you have tremors, you have chorea, you have dystonia, there should be some problem in this pathway. So direct, remember Parkinson's, indirect pathway, remember other movement, hyperkinetic movement disorders. So moving on to the phenomenology, basically, in broad, movement disorders can be classified, subclassified as 2 groups. Mainly hyperkinetic, as the name indicates, is too much of a movements. You see a person is doing so many things, you see a lady who's doing so many things, observe the patient. The too much of a movement is called hyperkinetic movement disorders. When you have too less of a movements, mainly trademark diseases, Parkinson's disease, it is hypokinetic movement disorders. So in hypokinetic, main 2 disorders. Hypokinetic is very easy. Hypokinesia is very easy. That is nothing but Parkinson's and other akinetic rigid syndromes. Well, hyperkinetic is a little complicated group of disorders where mainly to remember we need to know dyskinesia. Dyskinesia is nothing but dysfunctional movements in the body is called dyskinesia. So it's called hyperkinetic. So broad classification, hyperkinetic and hypokinetic. So when you talk, as I told, hyperkinetic is a little tricky. As you can see this patient, and mainly when you talk about hyperkinetic disorders, there are mainly 5 types. The 5 broad classification of hyperkinetic is tremors, tics, chorea, myoclonus, and dystonia. For each subtype, I'll show you a few videos so that you can remember what kind of movement it is. And again, to make it more simpler, in hyperkinetic movement disorders, you have 3 subclassifiers: jerky and non-jerky. So jerky, as the name indicates, it mainly includes tics, chorea, and myoclonus, whereas non-jerky is tremors and dystonia. This patient in the video has generalized high amplitude abnormal movements going in the neck. There's a lot of abnormal movements, chorea, dystonia. We'll explain that in the next part of my presentation. So before going ahead, first thing is history. As a patient comes to your clinic and then you're to OPD, these three things may be other basic things you know, but these may when you're taking a case of movement disorder, these three important things have to be emphasized. The first to be stressed in the history. First is the birth history, because most of the 40% of movement disorders which come later are because of either anoxia or perinatal insult. So always ask for any problems at birth. Second thing is family history. When you talk about Huntington's chorea, so many neuroacanthocytosis, they're all autosomal dominant or autosomal recessive or X-linked recessive. So always draw a three generation family chart when you're taking a case of movement disorder. Third thing is drug and toxin history, which is very common, where patients come with from the psychiatric OPD with a lot of neuroleptics, antipsychotics, and they present to us with a lot of movement disorders. So these 3 points have to be stressed when you're taking a patient of a history of case of movement disorder. In examination, first thing which I emphasize is cognition and speech. For example, if cerebellum is involved, you have scanning type of speech. So cognition, as Madam told, cognition is also important because most of these movement disorders also have associated cognition abnormalities. If it is birth asphyxia, they'll have intellectual disability. If it is Huntington's chorea, there's a lot of psychiatric abnormalities. There's a lot of dementia. Most of these chronic movement disorders, especially neurogenetic movement disorders, all have associated dementias. So emphasize on cognition and speech. Check for the eye movements. Spend time when you're examining the patient for eye movements, because most of these movement disorders will give us when you check the eyes, it will give us a clue for the diagnosis. For example, you're talking about atypical Parkinson's disease, you have vertical gaze restriction, and so many other things. So always check the eye movements. Gait, always, as I whenever a patient walks into your clinic, from the time they enter the room till they sit, and you make them walk, observe the patient for at least 10 to 15 minutes, you'll get a lot of clues, and you'll be able to make the diagnosis without even asking one question in the history. So check for arm swing, stride length, freezing, postural reflexes. Bradykinesia can be checked by, I'll show you the videos, repeated finger tapping, check for foot tapping, and always don't forget other organs and other systemic examination, because they also help us in giving clues for the diagnosis. So moving on to after taking the basic history, you divide your history into 3 parts. The first is phenomenology. First, you divide whether it's hypo or hyper, and then whether it is mixed, or just make up your mind whether it's hyper or hypo or mixed. Level 2 is distribution. Which part of the body is involved? What is the age of the patient? History, cognition, all those things. Level 3, move on to the investigations. Here, mainly, I'll be emphasizing. So first, we'll talk about hypokinesia. Hypokinesia, we indicate the slowness of movements. And trademark disease is Parkinson's disease. When you're talking about Parkinson's disease, it is very complicated, but to make it very simple, it's just 2 types: typical Parkinson's and atypical Parkinson's. Always remember, typical Parkinson's is slowly progressive. It will be asymmetrical. You have late falls, you have late dementia, late psychosis. All the problems are late. And when you start any dopa agonist or dopa analog, they do really well. They have more than 30% response with syndopa or any dopamine agents. Whereas when you're talking about atypical Parkinson's, usually it starts symmetrical. That is both hand tremors, both hands bilateral rigidity. They have axial rigidity. They start falling very early in the course of disease. For example, a typical Parkinson's starts at 40 years of age or 50 years of age. They progress up to 70, but still they'll be stable. They'll be very good on the drugs. They'll be doing really well. Whereas atypical, whatever dose of syndopa, they don't respond well. They'll be less than 30% response. They have a lot of falls, a lot of cognition abnormalities very early seen. You have dysarthria being seen early in the course of disease. You have a lot of psychiatric problems being seen early in the disease. So typical, atypical. Typical will be asymmetrical, unilateral, which will be syndopa responsive, less falls, less dementia, less psychiatric problems, less dysarthria. When you're talking about atypical, it always very rapidly progressive, symmetrical, early falls, early dysarthria. Always remember it is atypical, and you start them on syndopa. You see the response, it will be less than 30%. It will help us to prognosticate, because atypical Parkinson's, especially few types, succumb very early and they don't respond at all with the treatment. So that is the reason why you need to differentiate between typical and atypical Parkinson's. So going on to the videos, I have around 6 or 7 videos on typical Parkinson's, typical or atypical, what you see in the OPD. So it will help us to diagnose. So as I told, when a patient enters the OPD, you can see this patient. He looks very normal. Walking speed is good. There's no pedestrian gait or anything. But you observe his left hand, the arm swing is less. This young gentleman is a patient of young onset Parkinson's. Parkinson's usually is after 50 years. Any patient who comes below 45 with Parkinson's disease is called young onset Parkinson's disease. So this is very early in the course of disease. As I say, you need to have bradykinesia, rigidity. You can see in this patient, there's no bradykinesia, there's no rigidity, gait is absolutely normal. But observe this arm swing. Arm swing is comparatively less compared to the right side. So this gentleman has young onset Parkinson's disease. So that is the importance of seeing arm swing, making the patient walk. This is a very typical case of sorry, yeah. This is a typical case of Parkinson's disease. When you're observing him, you can see there is mask-like faces. Yeah, there is mask-like faces, decreased blink rate. Normally, patient has to blink less, at least more than 10 times in a minute. Here, you all can see the mask-like faces. The blink is absolutely not there. Then you ask the patient to bradykinesia. You ask him to alternatingly supine and pronate his arm. You ask him to tap his index finger at least for a minute. You can see the slowness. Usually, you ask him to do it for a minute because over time it starts slowing down. Then for lower limb Parkinson's, you check for ask him to tap the feet, the foot. It's usually slow when compared to a normal person. Do it on both sides. This will help us to do it. You should always check both the sides and compare both the sides, basically to see whether it's symmetrical or asymmetrical. So ask him to supine, pronate, tap, and then also tap his foot. Then you make him walk. You can see in this case, as a typical Parkinson, he gets up very slowly. He has a stoop posture, has short steps, walks very stooped, and turns en bloc. This is a case of very typical Parkinson's disease. Then, this is one more case of Parkinson's disease where the patient, they say resting tremor is very common in Parkinson's disease. You observe his left hand, there's a lot of resting tremors which you can see, very fine oscillations of the finger on the left side. When you talk about a tremor in Parkinson's disease can have any type of tremor, but the most classical is resting tremor and re-emergent tremor. So you basically check when he's resting, then you ask him to flex the hand, the tremors disappears. You again ask him to outstretch the hand, the tremors restart. That's called re-emergent tremors, which are very classical of Parkinson's disease. And this is one more video of a lady with there's something called tremor predominant Parkinson's, where they have bradykinesia, rigidity, but the tremor is very significant. You can see high amplitude oscillatory movements on the left side. Again, it is asymmetrical. So this is typical Parkinson's, not atypical Parkinson's. But what I have seen in my little experience is very different. As I was saying, this was tremor predominant Parkinson's disease, where you can see the asymmetricity. It's a typical Parkinson's with high amplitude tremors. Basically, this depends on which area of the substantia nigra is being involved. But it's very difficult to treat the tremors. And there's something called as camptocornea. This is seen in Parkinson's disease only, where you can see an extreme stoop posture of the patient. What is camptocornea is when you make them walk, they walk like this. But when you, when you make them walk, they walk like this, but when you ask them to lie down, the arch goes back. They'll be able to lie down completely supine. If it's a fixed spine deformity, they can never sleep properly. They still have that bent posture and even on supine position. But here you can see the patient can sleep completely supine. And when you make him to walk, he'll have a very bad stoop posture. It's called camptocornea. It's a very classical sign of Parkinson's. And this is called as pizza sign, leaning toward a pizza, where you can see the patient being leaned towards the right laterality. That is mainly because of axial rigidity. So this is one more case where you can see an advanced case of Parkinson's with pizza sign. Pizza sign also is very common in Parkinson's. As you can see, masked faces here. You can see alternating movements are very slow, and she has a right lateral tilt. That's called pizza sign. Okay, and this I had showed you earlier is a case of levodopa-induced disc kinesias, basically showing the risk of giving syndopa unnecessarily to a patient, which can cause these kind of, and you'll be surprised, it's very, very common in our OPD. At least in a month we see around 5 or 6 cases of this, and it's extremely difficult to treat this case. They have this kind of violent flinging movements, chorea, generalized chorea with dystonia, and they usually don't come down with any drug, and most of them end up with deep brain stimulation. So this is one more thing which we see when you talk about Parkinson's. Parkinson's never ends without talking about the gait. So here is a patient with gait initiation failure. That is initial, as the name indicates, the patient has difficulty in initiating the gait. Once he starts the gait, he starts walking. So usually the typical Parkinson's case is shuffling gait, short steps gait, as if they try to catch the center of gravity. And they always have gait initiation failure. As you can see, he keeps getting stuck. That's called gait freezing. And again, he starts walking. So again, he gets stuck. That's very classical of Parkinson's disease. It's called GIF, gait initiation failure. And small remedy which we can do apart from the drugs is you can order this kind of a stick. You can make a homemade stick like this. Have a horizontal bar in the in the bottom of the walking stick, and tell the patient whenever he has difficulty in initiating the gait, you ask him to step over that line, and they usually overcome that freezing. It's very common, and nowadays we're getting sticks with laser lights, horizontal laser lights. So whenever because these things don't improve with drugs. Whatever you do, gait problems, postural problems never improve with drugs. It's all exercise, fear the rehabilitation and things like that. And this is one small remedy which you can do, and I find it very useful. Nowadays we're ordering sticks with laser lights. So whenever they get stuck, they have a button in the proximal portion of the stick. They press that button. They have a horizontal line being projected on the ground, and they ask them to step over that line, and they do well. So in short, this is a olden style, a homemade kind of stick, but nowadays it's available. You can order it online. So, and this is one more case of Parkinson's, where it's called vascular Parkinson's. Basically, you have multiple small strokes everywhere. The typicality of vascular Parkinson's, upper body is spared. Upper body is very normal. In this patient, upper body is very fine, is very fast. You can see his alternate movements being very fast, but the lower body is very slow. So when you have a Parkinson's with lower body Parkinson's, they always think of vascular Parkinson's. When you get an MRI, you can see a lot of ischemic changes in the brain, and they also are very not very responsive to syndopa drugs, dopamine analogs. Then moving on to those are a few videos on Parkinson's disease which you come across in your OPD. Then moving on to the hyperkinetic disorders, as I told, tremor, tics, chorea, myoclonus, and dystonia. In that again you subdivide into jerky and non-jerky. Jerky is tics, chorea, and myoclonus. Non-jerky is tremors and dystonia. Tremors definition being, as you all know, rhythmic oscillation of a body part. Phenomenology, there are 5 different types of tremor. Rest tremor, as you saw in the video, it is at rest, as the name indicates. Postural is only on an outstretched hand. Kinetic is throughout the motion, throughout the action, they'll have some kind of tremor going on. It's called kinetic tremor. Task specific is when you ask them to write, when you ask them to pick up a glass, when you ask them to hold a cup, they have a tremor. That's called task-specific tremor. Second aspect, what you have to define when you have a patient of tremor is which arm is involved, unilateral, bilateral, head, tongue, or trunk. Third thing, is it isolated tremor or you have tremor with rigidity, tremor with dystonia, tremor with cerebellum. That is how you explain. All these things, when you go stepwise, you never miss the diagnosis. You just randomly mention tremor and not look for things, it's very difficult. So always have a protocol, always go as per the protocol, you'll never miss a diagnosis. And all these things help you to come to a final diagnosis. So resting tremor, as you all know, is usually seen in Parkinson's and also seen in essential rubral tremors also. Postural is usually essential and dystonic tremor. Kinetic tremor is seen in cerebellar disorders. So as I told, we have to pay attention for isolated versus combined tremors. This is basic classification of tremors. I will not go into detail of it. So the crux of the story, see whether it's isolated or combined with other syndromes, with other features, and then you divide whether it's unilateral or bilateral and come down to which particular type of tremor it is. For example, we have a combined tremor, you can see in Parkinson's, you can see in Wilson's disease, and things like that. Yeah, the next common tremor which we see in the OPD is essential tremor. As you all know, essential tremor is very benign tremor to begin with. It is usually because of genetic mutation of ET gene in the brain. And typically, essential tremor is isolated tremor of bilateral upper limb, and most of the time it's action tremor, mid amplitude, mid frequency. It should be present for at least 3 years duration, and with and without tremor in other locations. Example, it can be associated head tremor, voice tremor, and other tremors. But there should not be any associated other features. It should be isolated tremor to call it as essential tremor. How to exclude essential tremors? Some of the exclusion criteria being isolated focal tremors, orthostatic tremors, task and position specific tremors, sudden onset and stepwise increase or progression. You should not consider as essential tremor, and you should definitely look for other secondary causes of these tremors. So basic classification is isolated. You see main 3 important things are essential, task specific, and primary orthostatic tremor. I'll show you a few videos of each tremor. Then combined tremor, usually it's dystonic tremor that's seen in Wilson's disease. Then rest tremor, tremor with ataxia. So ET, as I told, it's a genetic heterogeneity which is being seen. And you can see this patient, he's got a head nodding, head titubation. So also, whenever a patient comes with head nodding, isolated head nodding, first thing you think is essential tremor. Second thing is, what you should think of dystonic tremors. This lady has isolated head tremor, mainly anteriorly oscillating tremor. This lady has got essential tremor. More in the hand than more in the head than compared to the extremities. But you should always check for bradykinesia and rigidity, which is absent in this patient. So this is one more case of classical essential tremors. You ask him to outstretch the hand. You can see the tremors being seen. It's very subtle, but it's usually bilateral. One hand might be a little more than the other. That's called essential tremors. First thing you check is you ask him to outstretch the hand and check for the movements. And there is one small test which you can do on OPD basis. This is called Archimedes spiral. You ask him to draw a particular circle like this. You draw a circle and ask him to follow that lines, and you can see the tremor. You can diagnose and confirm the tremor. And second thing is you can put a small into mark and ask him to point the pen nib on it. So if he's not able to do it, that means tremor is present. Sometimes, usually it's a very classical case, but most of the time you have very subtle tremors. So you can do the Archimedes spiral. That is, ask him to draw a spiral in front of you, and also ask him to put the nib of the pen, point it on the into mark. So that will help us to diagnose a subtle tremor. So conditions with rest tremor I've already told. Other rare tremors which we come across, this is called as Holmes tremor. Basically, it's a high amplitude flinging movements of the hand. The speciality of it is when you start observing it, it has all types. It has hyperkinetic, it has kinetic, it has rest. All the 4 subtypes, all combined is called Holmes tremor, and usually seen in midbrain lesions. This is called as Holmes tremor. So he's got kinetic, when you make it at rest, when you ask him to move his hand front and back in all directions, all positions, he has a tremor. That's called a Holmes tremor. It's a very difficult tremor. Most of the time, it's seen in midbrain to pontine lesions. Then orthostatic tremor, the video is not very clear. Orthostatic tremor is basically very subtle tremors of the proximal part of your limbs, mainly on standing, and it disappears on walking. That's called orthostatic tremors. Then this is a patient with cerebellar disease. Just to emphasize the importance of doing this finger nose test, where you can see a tremor, fine tremor, or incoordination all throughout his action. It's called he just shoots a particular point, and that's considered intentional tremor or hyperkinetic tremor. And this is a classical case of wing beating tremor. whenever you see this kind of a case, and it is whenever you're checking a person with tremors, first you check with outstretched hand and also ask him to adapt and flex his arms towards his central axis. And you can see this patient with high amplitude tremors. It's called wing beating tremors. Basically, they're proximally more than the distal parts being flinging. That's called as wing beating tremors, and most commonly seen very classical sign of Wilson's disease. And this lady has dystonic tremors. Very, very, very difficult to differentiate essential tremors and dystonic tremors. Essential tremors is easy to treat. Dystonic is very difficult. Most of the time, we refer them for Botox, botulism toxin injection. And this lady, you can see there is actually, if you observe the video, you have head nodding. There is alternate contractions of extension, and subtle in between. She suddenly closes her eyes. She has some contractions of lips. So this is called as a dystonic tremor. And moving on to chorea. Chorea, as I told earlier, it's called Saint Vitus dance. It's a quasi-purposive, irregular, brief, purposeless movements that flit from one body part to the other. You can see this patient. This is a patient with neuroacanthocytosis, where there is very gross flinging of his upper limbs and lower limbs, and there is a head drop. This is a very classical sign of neuroacanthocytosis. How to differentiate chorea and tics? Tics and chorea go hand in hand, but tics are suppressible, chorea is not suppressible. Tics are repetitive, chorea is not repetitive. Chorea is a quasi-purposive movement abnormality. And this patient, this young lady, any young lady, especially between 5 to 15 years, has these kind of abnormal movements, and it's called hemichorea, on one side more than the other. You can see quasi-purposive, some kind of abnormal movements on the right upper limb, lower limb, which are non-repetitive, non-predictable. This girl mainly has Sydenham's chorea. So any young girl who comes with this always reverts post-streptococcal infection. That's called Sydenham's chorea. Then some of the other causes of chorea are drug-induced basal ganglia lesions, Sydenham's, antiphospholipid syndrome, Huntington's chorea, neuroacanthocytosis. And it's a small diagram to help us to diagnose. Basically, whenever you have chorea, I told earlier that you should define which part of the body is being involved. So if a patient comes with facial or forehead chorea, mainly some abnormal choreiform movements in the face, starts off with the face, then always rule out Huntington's disease. When it's orobuccolingual, it's either tardive, that is drug-induced dyskinesias, or it is mainly Wilson's or PCAN mutation. Whenever you have a patient with one side of the body being flinging abnormally, only on the right side, you are in the casualty, you have a patient, suddenly they come with acute onset, abnormal movements, dancing like a very violent dancing movements, the right upper limb, right lower limb, or left upper limb or lower limb, always check GRPs. Most commonly what we come across is diabetic hemichorea. Correct the sugars, they'll be fine. Or whenever it's about three things. One is diabetic hemichorea, vascular infarct in the basal ganglia, or a demyelinating lesion in the basal ganglia, contralateral basal ganglia. But whatever I have seen, most common is diabetic. You have a patient, check sugars, it will be more than 500. So it's called diabetic hemichorea or diabetic steatopathy. So the lesson for the day, in the casualty, you have a patient with abnormal, very flinging kind of these kind of choreiform movements. Then you, for example, this. One second, sorry. Yeah, this kind, same example, but make it hemi. This is generalized chorea. If the patient comes with only right upper limb, right lower limb, or left upper limb, left lower limb, always check for sugars in the casualty. So that's about chorea. Then moving on to tics, as I indicated, tics are brief, repetitive, stereotype, predictable movements. It can be motor tic or a vocal tic. So motor tics are mainly eye blinking, head jerks, arm, leg jerks, complex sequences. Vocal are sniffing, grunting, and snorting. Simple tics are very common nowadays, especially post-COVID, because of kids being at home, not playing outside, most of the time stuck to the mobile phones and TV and increased screen time. We come across a lot of children with behavioral problems and a lot of tics, which are very, very difficult to treat, and medicines don't act. Most of the time, it's behavioral therapy and a lot of tic suppression therapy which is needed. So here's one video of self-injuring or self-harming tic in this kid, which is he keeps hitting himself, he keeps flinging things. You can see the video. He self-injures himself and he keeps on doing it again and again. You must be surprised. Every month, at least 5 or 6 cases come after post-COVID. What I'm seeing is every month, an average of 5 to 10 cases come with so much of motor and complicated tics to our OPD. Sorry. He keeps hitting himself. He has some kind of stereotypic movements present. There's one more kid you can see. There's an abnormal movement in the right shoulder, on his face, on his lips. He keeps doing it again and again, and it's very predictable. This is also a type of simple motor tic. Generalized. He has some kind of jerky movements seen all the time. The main thing you should differentiate is tic always is stereotypic, which is repetitive and predictable. There's one more case. This is just very rare type of tic where he just flexes the neck again and again. The video is not very proper. So you have three types of tic disorder: transient, chronic, and Tourette syndrome. Tourette syndrome is pretty rare. It's usually seen after 10 years of life. So late onset vocalizations, any patient in the old age comes with some kind of a tic or some kind of abnormal vocalizations, always rule out a secondary cause before labeling it as psychiatric disorder. So secondary cause like excitotoxic drugs like cocaine, amphetamines, degenerative conditions, new associations like idiopathic cervical or there's some condition called PKD, that is paroxysmal kinesiolytic dyskinesia, which is very rare. But any patient basically who comes after 50 years with tics always rule out other rare causes and don't before labeling them as psychiatric patients. Myoclonus, as you all know, it's a brief shock-like jerks. It can be physiological. It is fragment of epilepsy. Most commonly, what we come across in the hospitals are secondary to metabolic encephalopathies or hypoxic encephalopathies. So there are four different types of myoclonus which we come across: cortical, basal ganglia, brainstem myoclonus, and spinal myoclonus. So moving on to the video, this is the most common thing which we see in the ICU, especially cardiac ICUs post CPR, post hypoxia. You can see multifocal, brief, jerky kind of flexion movements in this patient. This patient had an arrest and post CPR, anoxic damage to the brain. Usually we get this reference from cardiac ICUs, ICUs in the hospital, multi-specialty hospitals. So this is a cortical post hypoxic myoclonus, also called as Lance-Adams syndrome. Basically, the prognosis is bad. That basically indicates that the brain is damaged significantly. Cortical damage is very significant. The prognosis is very bad. Then there's something called as brainstem myoclonus. It is usually proximal. When the patient has brainstem stroke or brainstem lesion, what happens whenever you raise the arm and drop the hand like this, they have a small jerk in the shoulder. You can see a small jerk. I'll just repeat it for you. Replay it for you. You can see a small, see the small flexion of the shoulder and upper part, proximal part of the arm. This is called brainstem myoclonus. Indicates there is brainstem dysfunction. Then comes this is called palatal myoclonus. You can see sudden jerky movements of the palate, soft palate. Whenever you see these kind of case in the OPD, always think of Guillain-Barré triangle. Some lesion in the Guillain-Barré triangle. This triangle is called Guillain-Barré triangle. You have a case, you can write it to the radiologist saying, kindly check the Guillain-Barré triangle for some pathology. There will be tumor, vascular lesion, or anything like that. But ask the radiologist to concentrate. Most of the time, the reports are normal. But as a clinician, you should tell them where to look for, and 100% you'll get a lesion in this Guillain-Barré triangle. Then comes the propriospinal myoclonus. It's a myoclonus and standing. Basically, when you tap on the back, you tap on the back, she has a small jerk. See, it's a very subtle myoclonus. It is secondary to some intraspinal tumor or spinal cord lesion where you just touch and you have a small jerk in the back, mainly on standing against gravity. That's called as propriospinal myoclonus. In this patient, you need to get an MRI cervical, MRI whole spine or dorsal spine to look for any very rare, but you do have something called essential myoclonus, very difficult to treat. But you can see this patient is absolutely normal with some amount of jerks here and there, jerky kind of flexion movements, sudden brief jerky movements. This is called essential myoclonus. Then this is called opsoclonus myoclonus ataxia syndrome, mainly seen in autoimmune encephalitis or post-toxic encephalopathies or some viral encephalitis. Multifocal, very gross, generalized flexion movements everywhere, sudden jerky movements everywhere. As the name indicates, it's myoclonus, and they should also have an eye abnormality also. I'll show you in the next video. One more patient with this patient, gentleman, had autoimmune encephalitis, NMDA receptor encephalitis with opsoclonus myoclonus ataxia syndrome. So you give IVIG, you give high dose steroids, they do well. And as the name indicates, it's opsoclonus myoclonus. Myoclonus part you saw in other two videos. This is the opsoclonus part which you see. This patient was HIV positive with infection involving mainly the brainstem areas. So you can see sudden jerky movements of the eyeballs. So that's called opsomyoclonus. As it's a counterpart of the body having jerky movements. You can see it in the eye, very violent eye movements. It's called opsoclonus. So it's called opsoclonus myoclonus syndrome. Usually high dose immunosuppression with IVIG or steroids should do the trick. Then moving on to dystonia. Dystonia is nothing but involuntary muscle spasms leading to abnormal posturing of the limbs and breathing movements tremor is a part of dystonia. You have isolated, combined, and paroxysmal dystonia as any other movement disorders. So usually there are two types which you need to know: young onset dystonia, adult onset dystonia. 2 points you need to remember is young onset dystonia starts from the leg, limbs, and then progresses upwards. Whereas adult onset dystonia starts from the neck, head, and then goes downwards. So in this patient, there's a DYT1, dystonia T1 gene mutation is there, and the patient has generalized dystonia everywhere. You see the video, the patient with every action, he has persistent contraction of the muscles. So he's not able to walk. He has, you can see his arms, fingers are flaying. He has contractions everywhere. It is not very smooth. And you make him walk, his legs go into contraction. Basically, every one group of muscle goes into persistent contraction. And this patient had DYT1 being positive in him, so he'll not be able to walk. Every muscle goes into contraction abnormally. That's called dystonia. Then this patient has adult onset dystonia. As I told, it starts on the upper lip. You can see persistent contraction of sternocleidomastoid, especially in the neck. He's got retrocollis of his neck. It's very painful. This is called cervical dystonia, isolated cervical dystonia in an adult. Then this child had Sandy-Fus syndrome with very significant dystonia on the back, especially the axial muscles. So she basically Sandy-Fus syndrome affects the extrapyramidal system, and they end up having a lot of dystonia and dyskinesias. In this child, there was a lot of dystonia, where you can see neck dystonia, back dystonia, and patient is not able to stand properly. And when you ask the patient to walk, also she has this antroclolis. So in this patient, usually we end up advising them giving Botox. We do an EMG, we check which muscle is contracting, and we end up giving Botox for them, and they do fairly well, but the treatment is extremely costly and rare. So it's pretty difficult to treat these patients. And there's one more patient with isolated neck dystonia. And there's something called as a writer's cramp, which we come across very commonly in our OPDs, where you ask them to give a task, especially write. So they'll not be able to write, and arm goes into persistent contraction. There's no fine, you can see a flexion at the wrist joint. They'll not be able to write. And they are also very resistant. We end up giving some medicines, but they don't usually respond to them, and they end up for Botox only, Botox or deep brain stimulation. So they'll not be able to write. Whenever you ask them to write, abnormal muscles go into inappropriate or abnormal muscles go into contraction, which are not supposed to go on contraction. That is called as task-specific dystonia or writer's cramp. Then this is one very common thing which we come across in the OPD, especially from ENT OPD, where they end up giving mainly Stemetil, prochlorpromazine, levosulpride, and things like that. Or outside doctors end up giving a lot of levosulpropide, or patient starts taking levosulpropide for 2 years or 3 years. They, especially drugs which have a lot of dopamine antagonist, dopamine blockage action, they come with this kind of dystonia. It's called cervical painful dystonia. So you have a patient who's walking like this with the neck being flexed posteriorly, retrocollis being present. First thing is to check for, you ask them the history of drugs, and most commonly it will be levosulpropide, which is a prokinetic drug. It's called tardive dystonia. Then this is one more patient with persistent left lateral bending. That is also one type of dystonia, where you can see that mainly the axial muscles being contracted or persistently contracted abnormally. And sometimes you do get fixed head tilt deformity, but there are some pseudo dystonias which can be seen. Most commonly, some bony deformities, either C2, C3 is blocked, or some lumbar spine vertebra are blocked. They also have this one, but they are all fixed dystonias. They're pseudo dystonias. They don't respond to drugs, and you have to surgically correct them. Some of the other last few slides remaining. These are from unusual, rare movement disorders which we come. This is called tongue protrusion or oromandibular dystonia, very commonly seen in neuroacanthocytosis. Whenever she opens the mouth goes into persistent contraction. The masseters go into contractions, and also tongue is persistently being protruded. This is seen very classically in neuroacanthocytosis. So prominent oromandibular dystonia is usually seen in acanthocytosis, neurodegeneration, brain iron accumulation, Wilson disease, Leschnian's disease. And this is called oromandibular dystonia. Especially in adult, you should rule out neuroacanthocytosis again. You can see persistent contraction of his platysma. He's not able to relax it. This is one of the forms of oromandibular dystonia. Then, as I told earlier, hemidystonia, hemichoria in your casualty, always rule out diabetic hemichoria. And also at the end of my talk, I am very happy to share that we have started off a study with young onset Parkinson's disease in our center, in collaboration with WIMS in my center and BKS Hospital, where we are collecting blood for whole exome sequencing. We are trying to find out why Parkinson's is very common. We are coming across a lot of patients with Parkinson's being started at 30 years of age, 35 years of age. So for all patients less than 50 years, we are sending whole exome sequencing. We are trying to read the entire genetic map of a patient who has Parkinson's less than 45 years, and we are doing it free of cost. It's a multi-centric study in association with the MedGenome Labs. So hopefully we'll be able to know which gene is being affected, and hope in the future we get a permanent cure. Till now, Parkinson's doesn't have a treatment. We just supplement drugs. We do a lot of rehabilitation and things like that. But there is no permanent treatment to stop the disease process. They say when a patient with Parkinson comes to your OPD with symptoms, that means almost 95% of the negrostriatal pathway is already gone. So there's no point. You just end up giving them analogs like thyroid abnormalities. You give thyroxine. That's all. Here we end up giving dopamine analogs. But in future, hopefully, by knowing the genetic map better, we'll be able to treat by modifying the genetic map of a patient, and we'll be able to pick up a disease very early. Very early, that is at least 10 to 15 years before the onset of the disease, which really matters in the prognosis of the patient. So we are doing a multi-centric study. If you have any patient who is less than 50 years, we'll do it at free of cost. The entire whole exome sequencing to send it outside will be around 46,000 rupees per patient. So we are doing it at free of cost. We'll give the reports and hopefully hope to collect. Already we have collected. It's been almost 2 months now. We have in my center itself. I have already collected 20 patients. So hope to reach. It's a 2-year study from. I think it will go on to 2024. So if you guys come across any patient, please send over, or you just give me a call. I'll send my person and they'll collect the blood. There's a small pro forma to be signed, and they'll have the genetic test done free of cost. And until we have an answer why it is happening, and for next generation we can find a cure for it. So if you come across, please free to call me, and we'll necessarily coordinate and try to collect the blood samples. Thank you, and thank you for the opportunity. Any questions you have? Hope it was useful and not boring, because I didn't pick a topic like stroke and infections and things which I think everyone knows, and it's very boring because stroke, you don't have any videos, it's all statistics. I'll be talking about multicentric studies and so much research being going on. I thought this would be more useful for you guys, because these are the cases which you see in OPD, and we should be, as a doctor, we should be able to pick up it right and pick it up at the right time and do justice to the patient and not give other drugs. So, and rather than treatment, I spoke more about diagnosis, and hope these videos help you to pick up at least one disease, at least Parkinson's in the future. That's the reason I chose this topic, and hope it was useful for you guys.
No questions? No questions? Any questions, any queries from previous scholars?
Any neurology questions also? Not just movement disorders. Anything in neurology?
The room is open for discussion. Any questions related to neurology can be asked.
As I mentioned in my speech, sir, we have noticed that there is an increase of incidence of neurological disorders, and I have also gone through so many papers related to this post-COVID or post-vaccination effect. Is it a fact or it is just a...
Still a large gray area, ma. I'll not say post-vaccination, post-COVID itself.
Post-COVID,
has
yes.
a lot of effect on the neurotransmitters.
Is that true that the rate of incidence of neurological disorders has increased markedly?
Definitely, ma'am. Even I have gone through.
How do you relate? So, what might be the reason?
So many theories, ma'am. They're still speculating so many theories. Each disease, for example, cerebral venous thrombosis or stroke per se, has increased post-COVID. They say the thrombotic factors are increasing. They're all speculating. No one knows. It's a very new disease. Still yet to, a lot of studies have to be done to confirm and come to a particular conclusion. But everything has an explanation, from brain fog effect to cerebral venous thrombosis to stroke to seizures, behavioral issues. Everything has increased, at least as per the studies, research also, and as per my experience also, all the CNS diseases have increased post-COVID, including migraine, basic migraine, tension headaches, everything have increased, and everything has theory behind it. But nothing,
especially dementia.
Dementia also, they say neurodegeneration.
Cluster headache.
Yes, ma'am, everything. And leave apart the research. Even in our OPD, we are seeing so many cases post-COVID, ma'am. Theories, a lot of theories have been speculated, but no confirmed study is still out, and I think it'll take some time. It's a very new disease and a lot of things to be learned now, including venous thrombosis, which we have seen many number of cases post-COVID. There are a lot of speculations, a lot of hypotheses as such, but there's no one particular cause why COVID has done increased so many disease post-infection. Vaccination, again, it's a very controversial topic, ma'am, but I feel it's post-disease than post-vaccination. Post-vaccination, there are very selected complications which we have come across, like GB syndrome. Very rare, very rare. The benefits are way more than the risks. So I think vaccination was a must in COVID disease. There's no doubt about it. But I feel COVID per se has caused so many problems than vaccination. Vaccination, at least now, after vaccinating so many people, we have so many very fixed complications which are seen, like any other tetanus or DPT which we give. Now we have set of complications. When you're giving COVID vaccine, we tell them that this is a problem, this might happen, but any day the benefit is way more than the risk. So I feel that's why vaccination is okay, but infection per se, it's very difficult, ma'am, to tell. There's a lot of hypotheses. It will be 5 more years or 10 more years into the research to tell this is a particular reason why this disease, the incidence has increased.
It was very informative session, sir. My question is when you are deciding the level of our target of our doses, how we are on what basis we are?
Always start slow, titrate it slowly. Don't start at a high dose. First is you see the disease state. There is something called UPDRS rating. So you rate the scale. You see at what rate the patient is fitting into. And my principle is start at very low doses. Be very patient. Explain the patient and slowly titrate it upwards. Don't start at a very high dose because they end up having dyskinesia. Not only dyskinesia, they have vomiting. It's not easy. Syndopa is not easy to take. So most out of 10, I think 5 patients will not tolerate any dopamine analog, not only Syndopa, any dopamine analog. Let it be natural or synthetic analog which you give. Always start slow and slowly titrate it upwards. Don't start at a higher dose because you have to give those tablets lifelong. There's no point in adding a high dose and giving him a cure for a day and having dyskinesis after 1 week. So my principle is start slow, go up, explain the patient, tell him the prognosis, tell him it's going to take time. They'll always listen to you. If you want instant results, it's not possible. Especially in movement disorders, you have to be very patient. Most of the drugs have a lot of side effects. So start slow, titrate it upwards very slowly, weekly, monthly, go up on dose. Follow up the patient initially for 3 months and then follow up after every 6 months. Slowly increase the frequency, the duration, and the intensity.
If they are already on 5 times per day, can we taper the dose if they are symptom-wise?
If they're already on 5 tablets, that means they need 5 tablets to function properly. You cannot taper. In an anti-epileptic, you can do that. In a Parkinson disease, you cannot do 5 tablets. He is a candidate for deep brain stimulation. So we remove one drug, he'll again go back. He'll start having off time. He'll start having bradykinesia, rigidity. The very fact that he's functioning on 5 doses means 5 drugs. That means you cannot. In an anti-epileptic, it's a polypharma. In an anti-epileptic, you can remove that. You can remove the last added drug. But in Parkinson's disease, you cannot. That means that much of dopamine analogs or agonists he needs to function. You cannot take a drug. 5 drugs very rarely we use. And by that time we send them up for DBSN.
Does any that antihypertensive drug have any effect on
Depends on which antihypertensive drug you use. Most of the drugs don't have. What are basically used? Most of the antihypertensives which we use regularly, amlodipine, cilnidipine, they don't have any interactions with the dopamine analog. Most of the drug interactions with anti-epileptics, with anticoagulants, anti-platelet agents, yes, I've seen, but not with anti-hypertensive. The basic which we use, I don't think so. It has any.
The stroke patients, can they get?
Yes, they do. It's fate, Nasib, that's all. Because we do come across a lot of, but I mentioned about vascular Parkinson's. Most of these multi-infarct states, which have repeated MCI infarcts, PCI infarcts, over time they end up having Parkinson's. It's very difficult, very resistant. They don't respond well. But there are instances where we have seen small infarcts and also Parkinson's. So that is fate, that's all. We do come across, and we have to treat the stroke part separately, the Parkinson's part separately.
In case of typical and atypical Parkinsonism, whether the pathology remains same or different, and the treatment plan in both conditions.
Totally different. Like we talk about synucleinopathies and tauopathies and things and microfibrillar protein accumulation when you go to pathological level. So the treatment is totally different. Atypical does not have a treatment. For example, you see a case of PSP. Patient walks in with rigidity, repeated falls. PSP is very common, which we come across in the OPD in atypical Parkinson's. So they usually come in the OPD saying he has recurrent falls. He keeps tripping and falling now and then. He's got slowness. He's got change in voice. Then your brain should be alarm. To start thinking of atypical Parkinson's. Then you check the eye movement, the vertical gaze will be restricted. So that is done. That's a death sentence. The patient will not improve. You have to prognosticate. You can try Syndopa for a month, but there will be no improvement at all. So you just try to make his life more comfortable and counsel the patient. The treatment is the pathology is totally different compared to typical Parkinson's and atypical. Atypical Parkinson's is a very vast group of disorders and very difficult to treat. A lot of studies are going in again genetical analysis. So in our study which we are doing, we are sending genetic analysis for atypical Parkinson's also. So I'm hoping that we get a cure in the next generation at least.
Namaste, sir. So my question is, where is the lesion? How to identify the location of lesion, sir? And suppose if the lesion is in cerebellum, if the lesion is in cortical spinal tract, so what are the symptoms? Like how to differential diagnosis, like UML or LML? Generally, sir, in neurology.
Localized, because skin is localized. That is our bread and butter.
Briefly.
I can go on talking for that for a day.
One day we will arrange that.
Localization. To make it very brief. So as you told, UMN and LMN. So brain, when you talk about central nervous system per se, first thing you divide is CNS and PNS. Central nervous system, peripheral nervous system. When you talk about central nervous system, it's the brain and the spinal cord. Peripheral is spinal cord to the anterior horn cell and the muscle, end organ, right? So UMN means from the cortex to the anterior horn cell. From the anterior horn cell to the periphery is called LMN, lower motor neuron cells. So any lesion up is called UMN, any lesion low is down is called LMN lesion. UMN lesions, usually everything is up, everything is hyper. So you have a patient with some tumor or infarct, that means in the brain it's upper motor neuron. They'll have hyperreflexia, they'll have hypertonicity, spasticity, upgoing plantars. Remember, everything is up in UMN. UMN is mother organ, so everything is up. When you talk about LMN, everything is low. Tone is less. Areflexia, hyporeflexia, plantars are flexors. So when you check everything low, that means the lesion is not UMN. You have a patient with stroke, you cannot have areflexia. Rare instances are there, but simplest thing is they'll have areflexia. When you check the plantar reflex, when you check the plantar reflex, it's flexure. That's UMN and LMN. Then again, most of the cortical hemispheric lesions, for example, infarct cannot be bilateral. Unilateral infarct, it's always the lesion is contralateral. If you have a same side lesion and you're suspecting the brain being involved, that means brainstem. Contralateral hemiparesis is always cerebral hemispheres. When you have ipsilateral weakness, that is cerebellum or brainstem. Then you go to the anterior horn cell. Anterior horn cell, usually when a patient comes in weakness, any patient comes with weakness, you decide whether it's UMN or LMN. In LMN, it's anterior horn cell, the nerve, the muscle, or a neuromuscular junction. So first thing we'll talk about is anterior horn cell. Anterior horn cell is always asymmetrical weakness. They'll say right leg is weak, left leg is weak, or right upper limb. Very asymmetrical. It will not be a very symmetrical weakness. There will be a lot of wasting. There will be a lot of weakness. Here, the dictum is the wasting is more than weakness. Your patient saying there's a lot of fasciculations here, there's no muscle mass, but he is able to lift buckets and lift objects. That means the wasting is more than the weakness. Then you should start thinking of anterior horn cell. Anterior horn cell is proximal equal to distal, asymmetrical, fasciculations, wasting more than weakness. When you're talking about a muscle disease, anterior horn cell like poliomyelitis, anterior horn cell ischemia, and so many toxic induced, snake bite induced. So those patients come with that kind of a weakness. You check reflexes, it's completely areflexia. You have a patient with spinomuscular atrophy, anterior horn cell involvement, they'll have areflexia. So anterior horn cell is areflexia, asymmetrical, proximal, distal, wasting predominant more than weakness. Whereas and fasciculations are a part of anterior horn cell disease. Then comes your muscle, peripheral nerve. Peripheral nerve dictum is length dependent. Peripheral nerve is length dependent, symmetrical. Diabetic peripheral neuropathy. It starts down, symmetrical, ascends upwards. It is never upper limb, lower limb. They say jum jum kaalinda sudavagutte, allinda mele hogutte. They will not say kai jum jum ide, allinda kela hogutte. That means it's not diabetic, it's something else. So that's not diabetic peripheral neuropathy. Okay. So peripheral now you will have areflexia to hyperreflexia. You will have flexor plantars, and the weakness or paresthesia is always symmetrical length dependence starts down and muscle. Muscle is always proximal symmetrical. Exemptions are always there, but the basic funda is it's proximal symmetrical. Wasting is equal to weakness. In anterior horn cell, wasting is more than weakness. Here, wasting is equal to weakness, and reflexes are retained to normal in muscle weakness. So your anterior horn cell, your peripheral nerve, then comes neuromuscular junction. Neuromuscular junction is very similar to muscle disease. To make it simpler, you have a lot of diurnal variation. You have exertional weakness. They have ptosis and things like that. So cerebral cortical hemisphere, contralateral, brainstem, cerebellum, ipsilateral, coordination problem, cerebellum, spinal anterior horn cell, asymmetrical, proximal, distal, wasting more than weakness. Now length dependent, symmetrical, hyporeflexia and weakness. Whereas neuromuscular junction, it can be very similar to muscle, proximal only, but there are a lot of exertional weakness and diurnal weakness. That's the basic difference. How do you localize this word? But you can go on and on. This much if you know, and you build up, you read books and you build it up. Yeah. See. Drugs, any drug which can cause dopamine blockage, any drug. Most commonly we see neuroleptics, antipsychotics, your prokinetics, antidepressants, antipsychotics. So they all can cause anything which blocks that pathway. Remember that hyperdirect pathway, a direct pathway, indirect pathway, something which blocks the direct, as man called antidepressants. Your that's very common. So, anti-histaminic, you give Stemetil, you give basic drugs, you give flunomazine for migraine. They end up coming with Parkinson's disease. So we do cover, it's a myth. Drug-induced Parkinson's nowadays what they're saying is they have underlying Parkinson's which gets precipitated by giving this kind of a drug. So, but yes, there's something called DAT scan, dopamine receptor scan. So a little complicated, but basically you do that scan, you see the receptor uptake. If it's not there, that means it's drug-induced Parkinson's. If it is there, again symmetrical, asymmetrical, and things like that. But history, basic history, you can pick up the disease. You don't need investigation, especially in neurology. History, 90% of the diagnosis is done. Examination, 10%. Have a very good hear, listen, be patient. You can make the diagnosis.